I have a mic. Can everybody hear me from here? Yeah. Is that better? So I'm going to try this. I warned Winston that if this was Saturday, I wouldn't be able to give the talk. This is actually the first day I got my voice back. So thank you for having me back. I was here, I think, last in 2013, 2012. And as I was, and thank you, Dr. Bender, and actually, as you'll see, it's perfect segue to what I'll talk about, which, I'm a surgeon, and this group is used to having meetings from a number of experts, far more expert than I am, about various options and treatments for prostate cancer. And I suspect many of you heard it before, and I'll touch on them. But I thought it was maybe reasonable. I'm middle-aged. I've been in practice 20 years, and I, hopefully, just more of a philosophical chat on just my experience of treating men with prostate cancer, men and their partners, and I think that's a big piece. So thank you for having me back, and forgive me if my voice starts to fade a little bit. So what I thought I just in terms of tonight, is we'll just sort of go over, just very briefly, the natural history of prostate cancer. I suspect many in this room know a fair bit about it. I recognize some of you, so thank you for coming and seeing me. I haven't seen some of you in a year, so hopefully I did okay. And then just some personal observations, and I'll just kind of walk through some of these things. And so we'll go from that. We know prostate cancer is common. We've all heard the stats. It's a very common disease. It's a disease of aging men. There's a genetic risk. And, it's common. And if you look hard enough, you'll find it in a lot of men. And while many men can live with prostate cancer, as I tell a lot of my patients, when you have such a big denominator, even that numerator is still a lot of guys, and I think that's sort of the challenge, and really in my mind is the essence of prostate cancer detection, evaluation, and care. In 2016, that slide doesn't project particularly well, but basically we're getting better across all boards in terms of treating cancer. If you look at two periods of time from the 70s and then again in the 90s, basically those are survival rates across the whole board for a variety of cancers. So we haven't won the cancer battle. We're doing better, and that's all thanks to research and smart people and advocacy and some of the things that I'm going to touch on at the end. And this is US data, and you can see with men, prostate's right at the top of the list in terms of new cases estimated in 2016. And this speaks to that. If you look at prostate, which is about 180,000, lung, which is 117, and just keep those numbers in mind. If you look at death, lung is a pretty high percentage, right? 85,000 from 117. That's a bad disease. Prostate cancer, 26,000 from 180. That's a big drop, but it still sits number 2 in men in terms of prostate cancer deaths and in terms of cancer deaths in men. And so that's a big challenge, right, as we try to advise patients why one cancer can maybe be left alone and why another one might want to be treated. And again, just overall, we've gotten better. The second column is, I didn't realize the room would be quite so big, so I'm sorry if that doesn't project very well. In terms of making a diagnosis, I think, for some it may be the first time where you might just have been diagnosed. For many, you've been through most of the journey. Not much really has changed at the core. I think at the core you need some clinical suspicion and clinical judgment. The PSA blood test, much maligned, remains a great test. It just needs to be used and interpreted responsibly and appropriately, a rectal exam and a biopsy. What is PSA? I'm sure you've all known about it. It's prostate-specific antigen. It's a protein produced by the prostate. It's not specific to prostate cancer, but it's specific to prostate disease. We know that men who have prostate cancer tend to leak, if you will, more of that PSA into the bloodstream, and that's what we measure, and that's what we pick up. But other things can cause it to also, to elevate, and I've listed some of them. Just having a bigger prostate, or if you draw it right after a urinary tract infection. So that's part of that clinical awareness and clinical interpretation. the standard transrectal ultrasound and biopsy. You make a judgment that I'm worried about prostate cancer. You have a conversation with your patient about what the odds are of maybe finding something, and then you offer them a biopsy. And in 2016, and there are some nuances that have changed, we still primarily at the start, at the first point, do a biopsy under ultrasound guidance. The dilemma is this, and you can see it in those numbers that I showed earlier, is that we can find lots of prostate cancer. Some of them become clinically important, and a percentage of them actually lead to death. And that's the challenge, is trying to figure out where do you fit on that spectrum. So there's lots of options for treating prostate cancer, and they range from watchful waiting to active surveillance, and I'm not sure if everybody understands the nuance between the two. Maybe we can talk a little bit more about that in the Q&A afterwards. There's surgical options. I'm a surgeon. We do what's called a radical prostatectomy, and I'll just touch on some of the advances in each one of these domains: radiation therapy, androgen treatment, which is hormones, second-line treatment, and eventually chemotherapy. This is the goal of prostate cancer treatment, is you want to protect the patient from prostate cancer, from dying of prostate cancer, and certainly whether it's surgery or radiation, you want to preserve quality of life, the two most important domains. And again, Dr. Bender and all of that survivorship stuff really touches on those other two domains, which I think as clinicians, we treat very imperfectly. Is optimizing urinary function and optimizing sexual function. So we talk about the trifecta, if you will. Active surveillance, this is actually a made in Canada success story. Laurie Klotz, a number of you might have actually been treated by Laurie. He really should be commended on being a leader in the whole active surveillance movement. When I was training as a resident in the early 90s, that's just when PSA was coming. So we got very good at finding prostate cancer. And I think we probably overtreated a lot of people, right? We were very indiscriminate. You label somebody as prostate cancer and they were treated, and the virulence of the disease wasn't adequately assessed, and the quality of life issues, quite frankly, were probably downplayed, if not disregarded for many years. So the idea was, can we better, if we have a diagnosis, can we find those that we need to treat? Can we make a judgment that some people early in the disease, it's safe to follow them for a while, and then based on certain criteria, make a judgment to intervene, and then leave everybody else alone. And this is something that we should be proud of as Canadians, and it's something that I think has really pushed things forward. How can you improve active surveillance? So basically, it's all about taking that Gleason score, which is a measure of how aggressive your prostate cancer is, and seeing if you can show progression or a higher Gleason score on biopsy. The new piece, and I won't touch on it formally, is the role of MRI. And I think MRI does have a rapidly increasing role in the management, particularly of younger patients who you might put on active surveillance to see if you can find something that you might have missed on the basic biopsy. And if you target that particular spot and you can demonstrate something higher, then you would treat that man maybe a little bit earlier and take him off of surveillance. So that's where surveillance will probably start to evolve towards. Again, like everything else, it's finding the right patient and correlating it with the financial, the economic side of the argument, particularly in our healthcare environment. In terms of surgery, this is just an anatomical slide. Is there a pointer on this? Yeah, right there. So that's a cross-section of the prostate. The penis, if you will, is out towards me. The bladder is in behind. So when we remove the prostate, there's the capsule. The disease is inside. It's what we call T2 disease. If it goes through the capsule, which is that edge there, it's T3 disease, and we worry a little bit more. The neurovascular bundles, when we talk about nerve sparing, they sit right here. So the idea behind nerve sparing is you deliberately cut this outer shell, you reach in and you just try and sweep these away, and then you remove the prostate here and here. The dilemma, of course, is you're cutting closer to the prostate, and with that, potentially running the risk of leaving a margin behind and these things. So these are all sort of judgments that we'll make with our patients, and it's, how aggressive you are with nerve sparing is in much part a function of the nature of the disease and how aggressive that initial Gleason score is. Surgery in the 20 years I've been involved has evolved more to doing it in a minimally invasive way. You've probably heard about robotic prostatectomies. There's a few people in the room who would have had it, who I've looked after, who would have had it done a conventional way. This is evolving in Canada. There's 4 sites in Toronto. There's our site, there's Princess Margaret, there's St. Mike's, and there's a smaller program at Humber that are involved with robotic prostatectomy. It's still surgery. It's not perfect. It has all of the same potential consequences. And I can touch a little bit more about that. But that's sort of the evolving state of where prostate cancer surgery probably is now in 2016. The surgical approaches are changing, and it really is a function of where robots exist or not. And so basically, in 2013-14, so these are the Maritimes. They're all done in an open way. The red lines and the blue lines together are what I would call minimally invasive or robotic approaches. It still is actually only in 4 provinces: Ontario, Alberta, BC, and Quebec. And it's an economic argument, and trying to find the sweet spot of where it works and where the fit is for our patients is the challenge. But these numbers are changing. In Ontario, this bar is increasingly, I think that's the Ontario graph, is increasingly eating away at that blue bar if you look at the latest iteration. IMRT, a form of radiation therapy. Again, radiation can be done this way, or with brachytherapy, where you put radioactive seeds. And this is changing so rapidly, most of us dumb surgeons, quite frankly, can't keep up with this. And the idea is can you target and kill the cancer cells in a way that is increasingly precise with MRI and other forms of imaging, and leave the surrounding tissue behind. There is, particularly in Toronto, there is now a tendency to merge the two, to give people a shorter course of the external beam radiation therapy, do brachytherapy, and then maybe shorten that 7 weeks to 3 weeks. So again, a rapidly changing field championed and run by our radiation oncology colleagues. Hormones have changed. Before 2009, the natural progression of the disease was it was confined, you treated it. If there was recurrence, it tends to be hormone sensitive. You would put patients on hormones to manage the testosterone, but eventually that population of cells that were hormone independent would eventually grow and take over. And then so when you got to that level, when you were sort of castrate resistant, it was really about pain control and managing symptoms and eventually death. The established roles for hormones are, as I've listed, metastatic disease at diagnosis. Even that has rapidly changed. There's a role for chemotherapy when people unfortunately present now at the time of diagnosis with obvious spread of disease. There was a landmark trial done about a year ago where you can actually give chemotherapy even in that hormone-sensitive stage, and there's a dramatic survival benefit to that. So even that has changed. But those are sort of the conventional established criteria. If you're going to have radiation and there's high-risk disease, you'll be on hormones for a while. And post-prostate cancer surgery if you find a lymph node. Lots has changed since 2010. There's been a lot of new drugs, and this is really all thanks to research and advocacy, and that's how that curve looks now. So when you're basically hormone resistant, there's secondary ways to manipulate that receptor. There's chemotherapy, there's second-line treatments, third-line treatments after that. So there's so much more we can do, and while it still may not be ultimately curative, the idea, the phrase I will commonly use is, our ability to kick the can down the road that much further is really quite dramatic in the last 5 or 6 years. Now it comes at a price, and again, that's in part what with Dr. Bender's, these novel programs that are being established. I mean, that's a big part of it, right? We can do a lot to manage cancer, but then we still have to manage the patient emotionally and physically and all of the other things that I don't think we do a particularly good job of. And so we've really shifted that bar very much to the further to the right. So, I think just some general observations, and the rest of the talk will really just be more like that. And you can still hear me okay? My voice sounds okay? So, patients are very sophisticated. Patients that walk into our office, they tend to be motivated guys. They've done some homework. They understand, often even before biopsy, some of the nuances of what we're trying to find. I hear PSA isn't perfect, or it's not useful. And so it takes some time, and they continue to challenge me, right? And it's great to actually have an active patient population who will ask you questions. As a clinician, it's way better than the patient that sort of leaves it up to me and says, just do whatever you think is appropriate. I actually am always scared to death of that kind of a clinical scenario, because I don't think it fully understands all of the nuances of what might come down the road. And I think a better informed patient also is better able to cope with the consequences of treatment. There's so much data to overcome. The internet is full of so much stuff. Whether it's a peer-reviewed medical journal or something off the internet, the first thing, whenever you read anything, is you want to establish where that's coming from. If it's from the New England Journal of Medicine, the first thing I'll always teach the residents is see who the author is. Every university, every place has a position of bias. We're a robot institute. We do this, we do that, we do the other thing. So presumably we're going to research things that we're interested in. And so there's always an inherent bias in that. And certainly on the internet in general, in terms of patient forums, things that are not peer-reviewed and are unregulated, there's always a sense, if you go to a site that says surgeryisbad.com, there's a certain bias to that, right? So I think that all needs to be managed. There's a lot of noise to sift through. Many men do become focused on that next big thing. You'll go through all of this. Well, what about this? And it's hard, right? And it's a complicated conversation because new technology is great. Data is what eventually tells us whether we're doing the right thing. The nature of prostate cancer and how it eventually bears itself out is it's measured over sometimes a couple of decades, right? And so having 1, 2, 3, 5-year data may actually not be good enough. So these are all things that we walk patients through that I feel, that I spend a lot of time, and quite frankly, I've learned from my patients how to discuss these things with them, how to, and I'll go back if I'm challenged and try and understand things a little bit more. And, that surgery radiation debate, this was pulled off one recent paper that said if you look at everything down the road, it tends to favor surgery. But what does that mean? That was published by a surgeon. And it may be true, but how do you measure that, right? So I think it's true. The types of treatment patients choose, it's a combination of a lot of things. Personal desire, their motivation, the motivation of their partners, where they live. I think that also impacts, if you're on PEI, where I have a small summer home, you might just have a route at the prostatectomy because you don't want to go to Halifax for radiation. That's a common thing somebody will say, right? So there's lots of things like that will influence decision making. And so I've touched on most of these things. I don't think there's any right answer in that whole treatment journey. I think as a general rule, when there's lots of options, that means nothing is perfect. And they all have potentially some holes in them that you need to at least understand, and then just figure out what's right for you and what's right for your partner. So I'll just touch on this. I just actually was just offline before I started. I was just talking to a little bit about that to one person, and I would not have actually, when I was training in the early 90s, I wouldn't have fully appreciated the enormity of this whole idea of the patient journey. You know, when you're a resident, first of all, you're too young and dumb, so you're just learning and you're training and you're trying to cram knowledge and gain your surgical skills, and you come out and you think you know everything, and then 20 years later, you realize you'll never know remotely close to what you need to, and I think our patients teach us that, right? And so it's an extraordinarily transformative life experience, full stop. And even if you're on active surveillance and you're not going to have anything done, you know, someone's hung a diagnosis of prostate cancer, and it always sits in the back of the mind. And I don't think, particularly as surgeons, you know, the further out I go and the older I get, the more I find myself disinclined to prescribe medications. And there's a lot of things, right? I mean, I usually will tell patients, well, what do you think we should do, or ask them, and I think that's a big piece. You know, typically you'll get a guy, I'll be running a Monday morning office, and there'll be an elevated PSA consult, and it'll be 6. You know, in the initial visit, you know, he's just wanting to get back to work. He's a little bit bored, a little impatient with me if I'm running a little bit late. You know, he sees you for the first time, and you walk through this whole thing, and you say, well, you know, I'm not quite happy for reasons X, Y, and Z, and maybe we should think about doing a biopsy, right? So that's sort of how it starts, right? I mean, I'm just a guy you're coming to consultation with, and then you have that conversation, and then everything changes, right? So after that initial consult, the biopsy itself, I'm a strong believer that urologists should do their own biopsies. And it's not because I think technically we do it better. I think, for me personally, I think it's a central part of building that relationship with my patients, because if you do it yourself, you've made that judgment, you brought them from consult to an initial procedure that may make them sick in terms of infections and bleeding. There's a subtle thing. You don't measure that. There's no textbook about that, but I think it helps either to instill or trust and credibility, or maybe make your patient run away from you. But it's almost kind of a trial run, if you will, for when you come back. And so, of course, the news is the big thing, right? You know, and that's it's amazing. You know, you'll sort of peek out, and I'll usually kind of set my office so that I'm just bringing back my post-biopsy patients at a given slot in time. And it ranges from, you know, complete and utter relief to, you know, obviously the complete opposite, and it's a hard thing, right? It's a hard thing to give bad news, and then to quickly be able to temper that and say, well, this is why I think you can not panic and you can go home and have a glass of wine tonight. And to give perspective, it's hard. No one's going to remember anything after you've got prostate cancer, after that first visit and the news. And so I typically and deliberately will try and not go down the rabbit hole of what we should do. Patients won't remember it. They'll make bad decisions. And so I almost always insist that they go away. I'll give them a report, give them some means to sort of do some research, and come back and have a chat. And usually before I come back for the talk, I almost always, unless somebody refuses, I'm a surgeon, I recognize my biases as a surgeon. We work in partnership with the Odette Cancer Center, so almost as a rule, I'll insist that my patients get a radiation oncology opinion before I see them back. And because I think that's important. I think you need to sort of see a fully informed radiation oncology opinion with the inherent biases that come with that, and then come back and talk to me with the inherent biases that come with surgery. And I think we're all humans, and I think we all have to understand that bias is central to everything that we have, and it's important. And then that's where the treatment options come, and I touched on them. And the bottom line is there's probably no right answer. I think the paradigm of when you make upfront, when you tell a patient or suggest to a patient you might want to do a biopsy, upfront being very honest with them and saying you might find prostate cancer. What I want to do is find what I like to call real prostate cancer, and then we are prepared upfront to separate the paradigm of making a diagnosis from needing to treat somebody. And I think if you can establish that up front, it goes a long way. And then the final thing, of course, is the whole issue that Jackie talked about, vis-a-vis survivorship issues. And that's a big piece. For spouses, the patient journey is identical. They usually plug in with the news, right? So, the initial consult, obviously they're not there. Most partners will come back at the news level. And I've been quite struck by how important the spouse is in the journey for a variety of reasons. I think you need another set of ears to take notes down. You need somebody to help you make those decisions, make sure you heard things properly. Help you decide what's right for you based upon your shared goals. And I think, some of the issues of inequity, I've been very struck, even just how patients recover post-surgery. So much of it is dependent upon their access to a family support network. Is there somebody at home? Do they have adult children? Do they have a loving partner? You just do better, and you just have, if you have that kind of infrastructure at home. So it's a very important piece. And I think sort of some general observations, and again, you touched on a lot of this, and I think the navigation program will actually touch on a lot of these things. I think men need to be coaxed to communicate. I don't think we're always very good at that. I'm not particularly good at expressing my own sort of thoughts a lot of time. We're often too busy, and I think we tend to sort of downplay that. But I think it's an important thing to get our partners to help us with that. And it takes a long time to adapt to changes. I mean, I'm under no delusion, and when we talk, we give every patient that we operate on numbers, right? Your risk of this is this, and your risk of that is that. But you're taking often a perfectly normal functioning individual, making a decision that you have to do something in the name of treating his cancer because it will harm him. But it changes, right? Life changes, I think, and I think you have to really understand and make people understand that. And I've been really struck over the years. I've learned so much from patients on this, right? Just sort of, and I watch to see how that spirit in their eyes has changed as they come to my office, year after year for follow-up. It's an ongoing thing, and it's hard work. And I think we need a whole network of multidisciplinary experts to help us with that. So for spouses and for partners, I think there's a lot of the same feelings, but a few specific things. I think there is a lot of fear and anxiety. Just deal with the cancer, take the cancer. There's a lot of mourning, I think, that comes with that. And then there's often, I think, a period of resentment. How the heck did this happen? We were a perfectly happy, highly functioning couple, and now we've had to make these adaptations. And this is hard. And so I think partners need support in their own right, and it's emerging. One recent publication, this was a Michigan survey. Michigan has done a great job in terms of measuring health outcomes. And they looked at, they gave the survey to spouses, and many really reported fair to poor communication with their primary care provider or their specialty care provider. A lot of doctors will touch on some of the sexual options, but at the end of the day, without good communication, only about 7% ultimately remain on that. And that's okay if that's truly by choice. But for me to really dig down 2, 3, 5 years later and really go back to that and say, are we really where you want to be? Is it okay? I mean, that's hard, right? It's hard work, and I don't think we do a particularly good job of that. This was a 2013, you don't need to read the numbers, except to say this was a New England Journal a paper that was widely quoted and studied, and it looked at 15-year outcomes in terms of whether people had surgery, radiation, and in terms of urinary domains, sexual domains, and bowel domains. and they all, at 15 years out, were not great. I mean, it was actually shocking, and we discussed this at one of our Twitter journal clubs a couple of years ago, and and it really was quite interesting that how imperfect, how we think we're doing and what the reality of it is. And it was really a bit of an eye-opener, I think, for everybody. I think we've historically done a poor job. I think we tend to focus on fixing the disease and, writing quick clinic notes saying his PSA remains 0. And I think we need to do better. And I think we are doing better. And I think it segues into what you just heard at the start. I think you need a big support structure. I think, this idea, for years I would tell patients just to get Kegel exercises. I'd kind of give them a little handout, and kind of walk them through it a little bit. But we've learned there's actually more to that. You can actually have dedicated physiotherapists that can help. I think there's a huge role for psychologists and family doctors. I think family doctors get often marginalized in this process, and I work really hard to bring them back in. It's like, yes, the care has gotten very specialized and very complex, and I think, and whether it's true in urology and prostate cancer, or whether it's true for any other disease, I think the more complex things become and the more imperfect life becomes, you need somebody to quarterback your overall care, to take the note from there, to take the note from there, and really kind of manage the whole thing. And I think really good family doctors want to do that, and we as specialists need to empower them to do that. And I think for surgeons, this is particularly a hard thing, this idea, when you get to that chronic phase 5, 8, 10 years out, to really make sure that we still ask the right questions. I really try. Do I think I do a great job? I'm not sure. I really try and aspire to do a better job with that. And I think that's hard because it takes a certain amount of clinical time to do it, and it takes active engagement and the right questions to ask. The PCC website's a great website, and if you actually just go to that Facing Prostate Cancer tab, which is right off of the main page, that's actually superb. There's a little section about if you're a young man with prostate cancer, if you're a gay man with prostate cancer, what does it mean for spouses? It really touches, I think, on some of the themes that have been not very well dealt with by all of us over the years. And so I think we're getting better, and we need to be better. And so the final piece is around advocacy, and I thought I'd just throw Rocco's picture from his Twitter feed yesterday. And for us, I think as physicians, it's about, there's always fundraising to do, advocating for research, really evaluating our outcomes, working across institutions, not in silos, to pool our data, managing threats to the gains we've made to date. And I'll touch on that, the whole controversy around PSA screening. For patients and for support groups, it's really about increasing patient literacy, patient and partner support, what you heard, this True North initiative, the idea of patients actually being the navigators and helping other patients to say, this is really how it might look. This is what we need to do. It's all a form of advocacy, right? And that was actually all fundraising, right? PCC fundraising, Movember. I grow a silly mustache every Movember, as some of you know. And these are some of the fruits of that advocacy at the end of the day. Stewarding the cause through various social media platforms, such as Plaid for Dad, which is June 17th, right? And Movember, Harry's Run, and then, the various forms of social media. And I think, for clinicians, the whole controversy around does PSA work, or my GP doesn't believe in PSA. I can't tell you how many times I hear that line in my office, and it's like, well, what does that mean? Since when did PSA become a belief system? What we do know is that with the advent of PSA, that was the widespread adaptation of PSA screening. We've made huge gains in prostate cancer. If we stop screening, we are going to see the number of people certainly eventually present with advanced disease, and then you'll see an increase in the death rate eventually. What we need to do better, this is the Canadian this was family doctor Canadian task force guidelines that were published in October 2014 by the Canadian primary care leadership in this country, with no active input from either radiation oncologists or urologists. They asked Lori some stuff, but there's no actual endorsement from Dr. Klotz or others. And basically they said, don't bother, don't check, right? Which is complete nonsense. And you can't do that. The American Urological Guidelines say, well, you can sort of check, but you know what? This is where it might be. There might be of some benefit and where it might not be. I wrote a little blog about that, and so I have a website and I do a little bit of blogging. So I think that's where our role can be on things. And I think, again, understanding that you want to find the right patient who has the right disease and maybe leave everybody else alone. And so this is sort of, I think, even in 2016, where I think, you know, in terms of prostate cancer detection, until we come up with better biomarkers, there's still nothing in my mind that's ready for prime time. But this is sort of how I see it. You know, I think, you know, you should, and I think the two biggest points are probably item 2, this idea of uncoupling a diagnosis from intervention, right? It's okay to make a diagnosis and have that conversation and tell your patient up front, I'm going to throw a big net in the ocean. I'm hoping to catch a few big fish. We're going to find a whole bunch of little fish, and we're prepared in advance to throw those back overboard, but we're trying to find those big fish. And unless we have a pre-biopsy way of better predicting where the big fish are up front, that's okay, right? But that's sort of how you have to think about it. And then I think item 4 is increasingly important. I think everybody should get a baseline PSA somewhere in their 40s. If your opening PSA is negligible, not normal, but negligible, less than 0.5, 0.6, you know, there's an increasing thought that you maybe don't need to follow such a patient all that frequently. Maybe he can get away with 3 or 4 PSA tests over the course of his life. If you can get to age 60 with a PSA of less than 1, your odds of developing meaningful prostate cancer is not particularly high. So a lot of those men, you know, so that may be where the screening debate eventually goes. And similarly, you know what, I tend to sort of turn up my spider sense a little bit when a 42-year-old man comes to my office, even if he has no family history, and his PSA is 1.4, 1.5. He doesn't need a biopsy, but I'll advise him, you know what, you might want to just trend your PSA out a little bit more closely. And my clinical experience over 20 years has taught me that that's right. You know, we talk about family history, ethnicity, blacks more than whites, more than Asians. But if you looked at my last 100 guys who I've operated on who are 55 and less, I would guarantee about 70% of them had no pre-surgical risk factor, and you know, and the known risk factors that we have, right? Family history alike. So how did we find them? It's about, you know, it's about a little bit of having a little bit of clinical suspicion and clinical intuition, and using some of these more nuanced thoughts around how to make better biopsy decisions. And then the last piece of advocacy, I suppose, would just be, so we're the Michael Garron Hospital, and you know, I mean, my Movember advocacy and has sort of morphed to other forms of fundraising, and so, you know, I'm very proud of this. The Garrons, you know, have been very kind supporters of our hospital, and I personally spent 3 years stewarding that particular gift, and it's a transformative gift, and we should always celebrate you know, the leaders in our community, particularly those that are so generous to give back like that. So my voice is just about done, and thank you with that.